take the role of the grumpy old man and throw a little bit of water, basically by looking at the data and trying to be very clear about what the data show. These are my disclosures. There are a couple of CAR T-cell companies that maybe don't like me anymore. So I'm going to stipulate a couple of things which I think are pretty clear to everyone, and I think Jeremy and I would certainly agree. So Jeremy showed you that great anecdote. Always beware an anecdote in a debate, because but in any event, I agree that there's a lot of exciting things going on with CAR T cells. They should be studied. I think it's good that we have them. I think certain patients should receive them. There are no doubt patients that have had a dramatic benefit. Everyone who's treated a patient or had a patient go to CAR T-cell has some great stories. You know, I think that clearly for some individual patients, this has made a big impact. But we do, as we approach the field, as we interpret the data, we have to look at the data, not the anecdotes in the big picture. No doubt, as Jeremy said, there will be refinements to this that will make things better as far as efficacy and toxicity. One big aspect of this that you all know if you follow the news is the cost and the availability of CAR T cells. You can say that that's going to affect its impact. That's not really a big part of my argument at all, so we'll stay away from that aspect of it. But clearly, if patients can't either afford the drug or have access to the drug, that's going to be a problem. I'm not going to make that argument as being why it's there, but I think one way or another those issues have to be addressed, and I won't really focus on them. So my premise here and the rest of my remarks are really that over the next 3 years, CAR T cells not in clinical trials, not the commercial available product, is not likely to have a major impact for the broad population of patients with recurrent large cell lymphoma. And I'll walk you through the data that support, I think, that statement. So first you have to say, well, what's a major impact? But I think for something to really be having a major impact, it can't be just anecdotes. Obviously, there are patients that their lives have been changed and rescued and so on, but it has to be something that helps significant numbers of patients. The benefit has to be clinically meaningful. There has to be reasonable toxicity, and again, the general availability I'm not going to focus on, but clearly if only a handful of patients have access to something, the impact is going to be limited. So this is the algorithm for large cell lymphoma. I'm not going to spend any time on it. Obviously, people get R-CHOP, they get second-line therapy, they get a transplant, and at the bottom of the list here, those that either don't get a transplant or relapse after a transplant are the target population, as Jeremy said to you, and those are the ones with the greatest unmet needs. So I thought it would be useful, and to come back to the math, what happens over time for a population? If a drug is going to impact a group of patients with a disease, you have to see what happens to these patients and put the findings you've heard about in context. So I chose this paper that came out in British Journal of Hematology, and I think this is a very useful paper to put all this together. This comes from the Iowa Mayo Spore, so you would say these are maybe slightly healthier patients than average. It's a prospective study, a prospective registry, 1,000 patients with large cell lymphoma, relatively recent years. And I think they're reasonably average patients, maybe a little better risk than average, but it follows patients from diagnosis through their disease course. And I think this is a useful paper. I know Matt Maurer, who's one of the statisticians for the course, the SPORE, has done a lot of work on this. They do this very detailed flow sheet, which I'm not at all going to go through, but it's a paper worth looking at. And what I've done is I've distilled the key points of this down to you, and I've normalized the numbers to 100%, or 100 per 100 patients, so you can see what happens to 100 patients. So you have to trust me that the numbers they had in their 1,000 patients, I've now converted to per 100 patients. So if you have 100 patients diagnosed with large cell lymphoma, 25 of them will have relapsed and refractory disease, 75 will be cured. Some of those will have either localized disease or CNS disease. We can debate what happens to those patients, whether or not they can. Certainly some could benefit from CAR T cells theoretically. Of those 20 patients, this is with standard therapies. Everything we have now, this is not CAR T cells, this is basically chemotherapy, auto transplant, and perhaps a few other new drugs. Of those 20 patients with relapsed systemic disease, 18 in this series, or 18 in this or 18 out of the 20 in this cohort would have been treated with aggressive therapy. I thought that was a little high, actually, but that's what it is. 2 out of the 20 got non-aggressive therapies. Of the 18, 10 of those ultimately got a stem cell transplant, 6 relapsed after a stem cell transplant, and 4 were basically cured, had long-term remission. So that is what happens to 100 patients, and that's what happens through the relapse setting. So if you do the math and you say, well, there are 72,000 patients a year diagnosed with lymphoma, 30% have large cell. We have about 21,000 large cell patients diagnosed a year. About 5,000 patients have relapsed refractory disease. I've just multiplied those percentages by the population. And so that you can see that there are about 4,300 patients with relapsed systemic disease. About 4,000 of them are headed toward a transplant or essentially being treated aggressively. 2,000 patients, if you use the Mayo-Iowa proportions, ultimately would get a transplant. And then the 1,300 would relapse after the transplant, 800 would be cured. Now, that 2160 sounds like that's what it should be. But when you look at the CIBMTR registry for 2015, which is the most recent data, only 1,400 patients with large cell lymphoma got transplanted. So those are the real numbers. So a third of patients that you would say would be appropriate to get a transplant at these centers didn't get it for whatever reason. So again, you have to figure that there's about a third of the patient population that would be the transplant population that for some reason aren't going to get a transplant. And I would say that some of those reasons would be why they might not get a CAR T-cell treatment. Maybe they're older, sicker, comorbid illnesses, live far away, et cetera. So again, that about a third of patients that are getting this aggressive transplant type regimen or should be getting it don't get it for whatever reason, if these numbers hold up nationally. So interesting observation. Jeremy tossed out auto transplant, but this is actually the CIBMTR. I just downloaded it. This is their slide. This is the overall survival after auto transplant. So we do think, and I've seen the curves, and I've even shown the curves. I thought these are interesting curves that come, and again, this goes back to 2005. So this is how they present it. Maybe the numbers now with more rituximab or less, but transplant is not necessarily, and I'm not a huge transplant fan, but at the end of the day, I don't think it's so easy to throw out transplant. It cures a meaningful percentage of patients, and we have decades of history with it. So I support the trial that compares CAR T cells to auto transplant, but I personally am not ready to say, oh, go get CAR T cells because transplant is useless. I think we need to see what those studies look like. So to go back to the use of CAR T cells and the assumptions, the indications may evolve over time, but in the next few years, it's basically the population we've talked about. It's not going to be used up front anytime soon. Whether or not ultimately, time will tell. It's not going to be used in first relapse or instead of transplant, except in trials. The population is really the second relapse or third line patients using this in the multiply relapsed patients. So adjust these numbers around when you're talking about impact, and this is basically the same slide that I showed you. The population to get CAR T cells that fits that indication is about 3,000 patients, give or take, okay? So is it really feasible that 3,000 patients in the US are going to get CAR T cells for their third line large cell lymphoma? Well, a lot of those patients are older, they have comorbid illness, they have other options, they may be offered other clinical trials, they have preferences, they're concerned about the toxicity, the logistics of getting to a center. Currently there, last I saw, 39 centers, but that's obviously increasing and a lot of people are working on that. Some of these patients are going to have chemo-refractory and rapidly progressive disease. They're going to not be able to get to a point where they can get it. However, one might argue that the transformed patient population might change this a little bit and the numbers might get tweaked, but you can think of lots of reasons. And if you think of your last, say, 5 patients with relapsed large cell lymphoma, I would say 1 or 2 of them probably, as you think of and what you know about CAR T cells, probably wouldn't get there for various reasons. And this is just a slide, this is from the MIT Technology Review that showed, and this has been updated, but you can see where the CAR T cell sites, I don't want to emphasize this too much, but other than to say that, for instance, if you're treated in Little Rock, Arkansas, which is not exactly a small town, according to this article, you'd have to travel 400 miles to get CAR T cells, and some of my patients are not going to travel 400 miles to get that. Now, that's obviously going to change, but you can envision there are a fair number of patients where this just isn't going to be feasible, although obviously more and more centers will be coming online. So how do these patients really do? Okay, if you look at these 2,160 patients using our thought exercise that aren't going to get a transplant, where according to the study I just showed you, the 2-year overall survival of those patients is about 19%. If you look at those relapsed post-transplant, they're likely more favorable if you look at that subset because they got to a transplant, they had chemosensitive disease. So you got to figure there somewhere at least 2-year overall survival around 20%. And if you look at the Scholar 1 study, again, it's got a lot of caveats. It's a broader patient population. But again, the 2-year overall survival for this population of patients is about 20%. And that's what the data show from what we have. So Jeremy showed you versions of these data. I'm just going to show you a little bit of data here to come in. But basically, I agree, a high response rate. Most of these of the responders are CRs. You note that there were 111 enrolled, 101 received the drug. So everyone doesn't get the drug for various reasons. Their disease progresses, maybe issues making the CAR T cells, a variety of things. All of the studies are not intent to treat. Some of them are reported in different ways. And that's a practical aspect as you approach a patient and think about doing this type of treatment. Jeremy showed you a version of this curve, and I agree. This is a nice curve to the extent that 40% of patients are in remission a year later. And is this long-term? Maybe, maybe not. We're all hopeful that that line is going to stay straight, but time will tell, and I think we need to recognize that we don't know at this point in time, although obviously we're optimistic. He talked about the toxicity. I'm not going to reiterate this other than to say that there are some patients who are not going to choose to get this treatment because they're worried about the toxicity. I'm not sure how many 80-year-olds have been treated with CAR T cells. I saw that the studies go up that high, but I'm sure that there are not that many, and I can think of a fair number of other reasons why you might not want to pursue this. So I think we have to keep that in mind as we looked at the impact of this type of treatment. So if you look at this, you have to keep in mind that 40% of those treated are in remission at 15 months. 10% of those that were intended to treat did not get to the therapy, okay? And that's just more or less the 111 enrolled, 101 received drug. So what do I tell a patient who I'm thinking about giving CAR T cells? Well, I say that you've got about a 1/3 chance that the disease or other factors are going to prevent you from getting the drug. You're not going to get there because either your disease is going to grow too quickly or the drug's not going to get here in time for whatever reason. And I think that's a fair combination assumption based on the data that are out there. That may change to some degree. They've got a 1/3 chance of responding, but progressing within 6 months, and that's what the curves show. And then 1/3 chance of having a remission of 6 months or longer. And I think if you normalize that 40% and make it intent to treat, I think it's reasonably fair to call that about a third, a third, a third. And so I would say that a patient has about a 1/3 chance of meaningful benefit, meaning longer than 6 months response, which might be longer term. Hopefully it will be. Probably that's a little lower if their disease is worse. And probably if they're older, one might argue that may not quite be so robust. But again, that would be a factor that I think about. So remember that from the Scholar 1 study, the overall survival in refractory large cell lymphoma with boring old therapies, no lightning bolts, is about 20% here. And those are the curves. So there are 20% of patients that go out several years, beyond certainly 1 year in this. So not great curves, but also not zero when we look with standard therapies, and again, without the same selection biases that we see in the prospective studies. And this just reminds you that I think this is a pretty robust number at this point based on the various studies. Again, a 2-year overall survival in this population of about 20%. So how can we view the population of third-line large cell lymphoma patients? Well, what I would say is that there are about 20% with standard therapies that have a 2-year overall survival. I've shown you those data. If you look at CAR T cells, there's about a third of patients overall that seem to benefit from CAR T cells if they are approached, if they're deemed appropriate candidates. I'd have to say that probably some of those are the same patients who have the 2-year overall survival or longer with standard therapies, and some of them have been rescued and wouldn't have that, and that's why this is kind of a Venn diagram. But the whole population is obviously 2/3 of everybody else, which is still a lot of room to go. So from the standpoint of the total amount of patients that are going to have a huge benefit from this sort of therapy, the total amount of your patients who walk in with relapsed large cell lymphoma, it's still probably a relatively small incremental benefit today. And if you do the math, and I'll go back to these numbers, you get 3,460 patients. About 700 had the 2-year overall survival with standard therapies. And again, playing around with the math, 1,140 potentially benefiting from CAR T, just looking at that, a third of the patient population. So you're probably impacting here about 450 patients. No doubt that not all these patients are going to get it to the therapy because they're not appropriate candidates. No doubt some of these patients will have had their lives saved, will give great anecdotes and great stories. No doubt we want these drugs available, but at the end of the day, the overall impact for this population is probably relatively limited. And so I think my conclusions on my last slide are that clearly CAR T cells have rescued some very refractory patients, but at the end of the day, we have to keep in mind, and patients ask us all the time, every day, should I get CAR T cells? At the end of the day, today, this subset is relatively small. Clearly, we're hopeful, and there are lots of clinical trials that people should participate in, and hopefully that will improve accessibility, efficacy, toxicity, and greater impact. And I think we should encourage patients to consider CAR T cells when appropriate. They should participate in clinical trials, but I think it's also very much incumbent upon us to be realistic in setting the expectations, because ultimately it's a relative minority. They're going to have the greatest impact today. And with that, I will stop. Thanks very much.